Hi everybody, and welcome to our module on preterm labor. The definition of a premature birth is delivery of the baby before 37 weeks gestation. And when this happens, the baby will be a preemie, like what's shown in the picture here. And most of the babies in NICUs in the United States are preemies. They have many complications. So we do everything we can to prevent premature birth from happening and help pregnancies to reach 37 weeks, which is term. The strongest risk factor for premature birth is a prior premature birth. So once a woman has had one preterm baby, she is at high risk for having another if she has a subsequent pregnancy. Some other risk factors are shown on the slide here. Multiple gestation pregnancies often lead to premature births. If there's any problem with the cervix, this can lead to premature birth. So if the cervix is short, this is a condition called cervical insufficiency, which I talk about in another video. This raises the risk of premature birth. Any woman who's had prior cervical surgery, like a conization or an excision for intraepithelial neoplasia, these women are at higher risk for preterm birth. When there's a short interval between two pregnancies, less than 6 months, this raises the risk of premature birth. The idea here is that the cervix does not have time to recover and prepare for a second pregnancy. Smoking is a risk factor for premature birth. Any genitourinary infection, like a UTI or asymptomatic bacteriuria, this raises the risk of premature birth. And then just like multiple gestations raise the risk of premature birth, women with polyhydramnios who have a larger than usual uterus are more likely to develop a premature birth. A closely related topic to premature labor and premature birth is PPROM. PPROM is preterm pre-labor rupture of membranes, and this refers to rupture of the membranes prior to regular uterine contractions that occurs before 37 weeks. And PPROM occurs in 1/3 of preterm births. When a woman ruptures her membranes early, this is often a sign that preterm labor and delivery is coming. There's an increased risk of PPROM if a woman has had this problem happen to her previously, and also if there's a short interval pregnancy. And then it's very high yield to know that genitourinary infections increase the fragility of the fetal membranes and make PPROM more likely. And this is why we screen for these infections and treat all these infections. And in any woman who has PPROM, one thing you have to consider is that she may have a urinary infection that led to rupture of membranes. For any woman with PPROM, she has to be admitted for inpatient monitoring. That's because there is a risk of preterm labor and birth, but also because once the membranes have ruptured, there's a high risk of intraamniotic infection. And I talk about this in detail in other videos. Also, when the membranes rupture early, there can be a placental abruption. That's because the loss of fluid can lead to decompression, and this can cause the placenta to abruptly pull off from its attachments. There's also a risk of umbilical cord prolapse once the membranes have ruptured, especially if the baby is breech, and this can lead to fetal compromise. And then once these women are admitted to the inpatient service for monitoring, it's important to know that they should not have digital exams because this can introduce bacteria. So this may or may not come up on your boards, but on rounds, on your obstetric rotation, on a woman with PPROM, when the attending asks what to do next, don't say a digital exam because those are usually never done in women who have ruptured their membranes early. Once you admit women to the inpatient service with PPROM, let's talk about the management. If there's evidence of infection or fetal maternal compromise, then the baby should be delivered. So one of the major risks after the membranes have ruptured is chorioamnionitis, an infection. So if you see things like maternal fever or persistent fetal tachycardia, these are signs of infection, and these are indications for delivery no matter how many weeks gestation has been achieved in pregnancy. If the mother and the baby are stable and the pregnancy is at 34 to 37 weeks, then usually what's done is delivery of the baby. So 34 weeks is kind of a magic number. Once you get beyond this point, even though the baby is premature, the risks of delivery are smaller than the risks of prolonging the pregnancy. So delivery is usually done beyond 34 weeks. The ACOG recommendation is to induce labor, although in some cases cesarean delivery is necessary. Now, if the mother and the baby are stable, but it's less than 34 weeks, then you're going to hospitalize, as I said on the last slide, and you're going to do what's known as expectant management. This basically means you're going to try and get the pregnancy to 34 weeks and hold off labor and delivery. One of the things that is done is to administer maternal corticosteroids. These help to increase surfactant production in the baby so that if the birth is premature, the baby will be less likely to develop respiratory distress syndrome. And then the second major intervention is prophylactic latency antibiotics. So let's talk about that now. Latency antibiotics are prophylactic antibiotics given to the mother to reduce the risk of infection. Once the membranes have ruptured, bacteria can get into the amniotic cavity, causing chorioamnionitis, and this can cause labor and delivery to occur. So they're called latency antibiotics because after women have ruptured membranes, these drugs prolong the latency period, which is the period between rupture of membranes and delivery. The usual regimen that's used is azithromycin and ampicillin, although there are many other options. The idea is to cover group B strep, some gram-negatives, and anaerobes. And so the ACOG recommendation is that antibiotics should be given to women who have PPROM before 34 weeks. Women who have PPROM after 34 weeks do not need latency antibiotics. As I said in the last slide, those women can be delivered. It's the women who have very early PPROM before 34 weeks that should receive these drugs, and the idea is to try and prolong the time until delivery so that the baby can develop more. Okay, moving on, let's talk about the clinical features of premature labor. The clinical features of premature labor are the same as the features of any labor, and they involve regular uterine contractions plus cervical change. Now, sometimes the diagnosis is unclear. This can be a challenging part of obstetrics, especially if the amount of cervical change is small and the dilation is less than 3 centimeters and the membranes are intact. When you have a woman who has contractions and features like this, it's hard to know whether she's truly in premature labor or not. So in these cases, there are two tests that are often done as further evaluation. One is a transvaginal ultrasound, and the other is measurement of the fetal fibronectin. So transvaginal ultrasound is always used during pregnancy to measure the cervical length at 16 to 23 weeks. And that's because cervical length always shortens during pregnancy, and if it becomes very short before 34 weeks, then this raises the risk of preterm birth. But what this means is if you have a woman with possible premature labor, but her cervix is very long, which is greater than 30 millimeters, this has a very high negative predictive value. In other words, it's very unlikely this woman is going to have a preterm birth if her cervix is this long. And so this is why transvaginal ultrasound is very helpful in assessing women with symptoms of premature labor when you're not sure that they're in labor. The other test as part of evaluating possible premature labor is measurement of the fetal fibronectin level. This can be measured between 22 and 34 weeks. It's always high before 20 weeks, so it's not useful for diagnosis until you get to at least 22 weeks. And fetal fibronectin is a protein found at the decidua-chorionic interface, and you can detect it in cervicovaginal secretions. So you can take a sample and send it to the lab, and if there is evidence of significant fetal fibronectin at 22 to 34 weeks, this means there's a high risk of preterm delivery within 7 days. And so once again, just like with transvaginal ultrasound, if you're evaluating a woman with possible premature labor, the fetal fibronectin level has a high negative predictive value, okay? If the level is very low, then it's extremely unlikely this woman is truly in premature labor because the negative predictive value is so high. In women who are in true premature labor, you expect to see a short cervix by transvaginal ultrasound and a high level of fetal fibronectin. Once women are definitely in premature labor and you're sure of the diagnosis, the steps in management are shown in this slide. Once again, if it's beyond 34 weeks, you admit the woman and deliver the baby. 34 weeks is that magic number beyond which it's safer to deliver the baby than to make attempts to continue the pregnancy. If it's before 34 weeks, you're going to try and pause the pregnancy as long as possible to give the baby time to develop. First thing to do is once again to give maternal betamethasone to increase surfactant production in the baby. Also, before 34 weeks, all women in premature labor receive group B strep prophylactic drugs. Usually it's penicillin, ampicillin, or clindamycin. We screen women for their group B strep status, but this usually isn't done until 36 or 37 weeks in preparation for delivery. When they come in labor at 34 weeks, usually you do not know their group B strep status, and therefore prophylaxis is always administered. And then beyond betamethasone and group B strep prophylaxis, tocolytic drugs are used to delay labor after steroids have been given, and we'll talk about tocolytic drugs in a minute. And then lastly, you may know that magnesium sulfate is given to prevent seizures in women with preeclampsia around the time of delivery. But there's also limited data that it's neuroprotective for the fetus in babies born prematurely. There are some studies showing it can reduce the risk of cerebral palsy. And so there's an ACOG recommendation to give magnesium sulfate for neuroprotection in the fetus in early preterm births. So this usually means babies that are going to be born before 34 weeks. They generally are given magnesium sulfate for this indication. So tocolytic drugs are drugs that prevent uterine contractions, and they're given to pause labor in women who present in premature labor and try and prolong the pregnancy. Ideally, you want to delay delivery of the baby at least 48 hours because that gives time for the steroids to work, but if possible, you want to delay it even further than that. The drugs that are used are shown on this slide. Indomethacin is a prostaglandin inhibitor. This is the first-line therapy in women who present in premature labor at 24 to 32 weeks. The problem with giving it beyond 32 weeks is it can cause constriction of the ductus arteriosus in the fetus. And for that reason, you also try to avoid giving this drug for more than 72 hours. Once again, it can constrict the ductus arteriosus. Also, when you give prolonged indomethacin treatment to women who are pregnant, that can lead to oligohydramnios. Another option is nifedipine, which is a calcium channel blocker. This is often used when indomethacin fails, and it's the first-line therapy in women who have a contraindication to indomethacin. Side effects of this drug are all related to the fact that it's a smooth muscle relaxant, so it can cause hypotension and flushing. It also often makes mothers tired. And then the beta-2 agonist drugs are ritodrin and terbutaline. These used to be the first-line therapy. They're now used much less commonly. They've been largely replaced by indomethacin and nifedipine. There are a couple of interventions that can be used for prevention of premature labor in high-risk groups. The first one is supplementation of progesterone. This can be done either vaginally or through injections. And the idea here is that progesterone maintains uterine quiescence, meaning it prevents contractions from developing. Progesterone also decreases the risk of rupture of membranes. The other intervention is cervical cerclage. This refers to surgical reinforcement of the cervix. This is shown in this image on the screen here. You have a cervix which is somewhat dilated, and then after cerclage, it's been surgically reinforced. These interventions are used only in high-risk groups, and the major high-risk group is women who have had prior preterm labor. In these women, most obstetricians consider recommending progesterone supplementation. Also in these women, they usually have serial transvaginal ultrasounds through 24 weeks of gestation, and if any of those ultrasound exams identifies a short cervix less than 30 millimeters, then progesterone is recommended plus cervical cerclage. The other high-risk group is women with a short cervix but no history of prior preterm labor. In these women, usually progesterone alone is recommended. Usually the indication is a cervical length less than 25 millimeters before 24 weeks. And that concludes our module on preterm labor.